It stands for Health Economics and Outcomes Research. So at AES this year, we had the opportunity to present 6 HEOR posters, 6 health outcomes posters, 2 of which focused on an ad hoc analysis of the phase 3 eslicarbazepine acetate clinical trial population. We also had a poster that was based on a large database of patients with epilepsy in the United States. Post hoc analyses focused on changes in depressive symptoms and quality of life among patients enrolled in the phase 3 monotherapy clinical trial population. What we found was that among patients who had a response to eslicarbazepine acetate monotherapy, patients also had clinically important improvement in quality of life as well as depressive symptoms after 10 weeks of therapy. What we actually found in our study was that patients who responded by showing a decrease, a 50% decrease in seizure frequency during the trial, actually had improved depressive symptoms. So it's almost indicative that an improvement in the epilepsy is having an effect on patients' depressive symptoms. We hope that these findings are impactful for healthcare providers. As we all know, the healthcare system is becoming more focused on improving quality as well as reducing costs among patients with all kinds of diseases, including partial onset seizures. And so our aim with our health outcomes research is to provide healthcare providers with the tools to potentially make an impact on patients' outcomes and costs as well. Another of the analyses that we had here was a large claims database study of patients with epilepsy. In that study, we looked at the association between pill burden at monotherapy initiation and the incidence of hospitalizations and emergency department visits over a 12-month follow-up period. What we found was that higher pill burdens, or the greater number of pills taken per day by patients on monotherapy, was associated with a 15 to 25% greater risk of hospitalizations and emergency room visits over a 12-month period. We classified patients into distinct groups of 1 pill per day, and that was a reference group. And we compared patients taking 2, 3, or 4 or more pills with patients taking one pill per day. And that's where we found the increased risk. Well, it's well known in the literature from other therapeutic areas like antihypertensives or nephrology or even antivirals, HIV treatment, that a greater pill burden is associated with decreased adherence among patients who initiate treatment. And so we were able to confirm a similar signal among patients with epilepsy, and these findings may be useful to clinicians as they look for opportunities to improve health outcomes. Both things are important. It's important to find the best treatment possible for patients, but also one that imposes the least possible burden on their ability to take the medication day after day. It's an important way to try and improve patient outcomes as well as quality of life. The key takeaway from our studies, for example, the large claims analysis that we did, is that pill burden is associated with hospitalizations and emergency visits down the line or in the following months post-initiation of monotherapy. It's useful to remember that seizures account for about 1 million emergency room visits per year in the United States. And so just keeping in mind that something as simple as pill burden can have an impact on that could be useful in making an impact in reducing emergency room visits. There are approximately 1/3 of patients out there with epilepsy who do not respond to treatment. So there's a long way to go in that sense. We are committed through our health outcomes research to finding ways to optimize the health care of these patients. Quality of life measures are important because they provide insights into what's going on with patients' lives as reported by patients. No one else but patients can tell us about their social functioning. No one else but patients can tell us about their emotional and physical well-being, among other variables. So it's important to maintain our focus on quality of life assessments, because through these insights we can make an impact on important health outcomes for patients. I think all healthcare practitioners should be aware of what makes a difference to patients with epilepsy, and providing the best quality of care is certainly chief among those concerns. Patients also need to be informed about their treatment options and not give up hope. There's plenty more that can be done for patients. A long way to go, but in the coming years we will stay committed to tracking down any insights that can help healthcare providers improve patient care moving forward. There's a high unmet need in epilepsy, in part, or in great part, due to the fact that not all patients respond in the same way to a given anti-epileptic drug. So having lots of options to treat patients with is paramount. Tolerability is a great issue in epilepsy as well. And so finding the drug that patients can tolerate, or the right treatment regimen, not just drug-based, but also support-based, is important. That's why quality of life measures are so crucial, because only through those measures can we know where the work is. Is it in improving patients' physical functioning, or is it in improving patients' social or emotional well-being? In the coming years, that will give us a lot of evidence to help improve patients' lives. Epilepsy affects patients' ability to drive, to get to work, to keep work, and epilepsy takes thousands of lives every single year. So we have a long way to go, and we need to stay focused on coming up with every possible shred of evidence that can help patients have better lives.